A year ago, many of us had never heard the term COVID 19. In fact, it wasn't until February 11th, 2020, that the World Health Organization announced that the disease caused by the 2019 novel coronavirus even had the official name COVID 19. The sudden, pervasive impacts of this brand new virus, so new it even had the word novel in its name, has tragically killed over 2 million people in just a year and has turned every aspect of our lives upside down. We've heard from the media and government that we are living through something truly exceptional, even unprecedented, that we still barely understand COVID 19, which is true. But in another sense, we understand COVID 19 extremely well, too well, I would argue. Without knowing exactly what this disease was, how it spread, or what its exact effects were, everyone could guess who would suffer first and most. I'm Mariana Arcaya, an associate professor of urban planning and public health at MIT. As a social epidemiologist, I study population level patterns of health and disease. What social epidemiologists know, based on centuries of data collected across the globe on hundreds of health outcomes, is that low socioeconomic status, exposure to racism, lack of power, and other forms of social marginalization are fundamental causes of disease. For any disease you can think of, there's a unique set of factors that put people at risk of developing that disease. But fundamental causes of disease are factors that cause lots of diseases and put people at risk of lots of health risks. That means it doesn't really matter what the disease is or exactly how it spreads. Socially vulnerable people are going to be at elevated risk practically every time. At MIT, I run a participatory action research study in collaboration with the Conservation Law Foundation, local community-based organizations, and residents. Together, we understand how different aspects of neighborhood environments create health risks and what we should do about them. Here are some pictures of my MIT students going out with community-based resident researchers to collect data in the field. In typical research, academics think of a hypothesis on their own and then check to see if the data support it. Participatory action research turns this model on its head. First, we work hand in hand with affected communities, people with lived experience of the issues we're studying, to understand their perspective on the challenge and what we need to do to solve it. And then we check to see if the data supports their hypotheses. We know that the residents of our study communities are the experts in understanding what they need in their communities to be healthy and what's putting their health at risk. By asking and answering a question, this is only the first step. We use the results of our research to work together to try to affect change based on our findings. So when COVID-19 hit, we built on 5 years of partnership researching community level determinants of health, and we put our model into action. In March, when there were less than 1,000 cases of COVID registered in the state, we knew from our research and our partners' lived experience that our study communities, such as Chelsea, Brockton, Lynn, and Everett, were bound to face disproportionate COVID risk due to unfair social inequities in economic, social, transportation, and housing conditions. Unfortunately, but predictably, we were right about the rates. And we saw that by summertime, the municipalities I just named were among the most highly affected places in Massachusetts. But being researchers, it wasn't enough to know where the cases were. We wanted to rigorously understand what mechanisms were creating the excess risk that we knew would be there, and to help advocates and policymakers address these risks to improve conditions for health. Our first step in getting to the mechanisms was to really listen to what residents of our study communities said in their own words about the risks and challenges they faced in their daily lives. Qualitative data from our study pointed to housing costs as a key theme. Residents in Chelsea, the Massachusetts city with one of the highest COVID-19 case rates, raised housing costs as a serious problem. One resident in our study told us, "There's a lot of people in Chelsea that are renting out rooms in houses because they can't afford the rent." Another respondent, a 50-year-old woman working 2 part-time jobs, one in a school and one in a supermarket, has been renting one of these rooms in Chelsea for 3 years. "I live with 5 people that I'm not related to," she said. A homeless respondent from Brockton, another highly affected city, says housing costs prevent him from getting off the streets, telling us, "And my biggest concern myself is I'm homeless here. I want to move somewhere where the housing is a little cheaper, but because I couldn't afford, not on my own anyways, I've stayed at a few relatives' houses and then at a homeless shelter up the street. So that's about 5, 6 places. I paid them rent, or I tried to. I tried to give them what I could." So learning from residents was the first step. And the next step was following the leads these residents gave us to investigate patterns in the Massachusetts COVID dataset. We used the official state database on infection rate, which many universities are using in COVID research, but we combined it with data on housing market trends to predict disease spread, something the other researchers had not done. And what we found matched up well with what residents were telling us, that their housing costs were so unaffordable and going up so fast that they were living in unstable or overcrowded housing, conditions that we now recognize as COVID risk factors. So take a look at this. Here's a map of Massachusetts with each municipality colored according to COVID-19 case rates as of this summer, which is when we completed this analysis. The darker the color, the higher the share of people who had gotten COVID. And when we add an outline showing the places that have seen the highest percent increases in housing values over the past 5 years, we see a close correspondence with the places suffering high COVID rates. When we test this relationship statistically, we find that on top of other factors that have been used to predict COVID case rates, for example, local poverty rates, density, employment and work from home jobs, and other factors, housing market factors still matter. We see that rapidly increasing home values, especially in places that have until recently been affordable, is an independent risk factor for COVID spread. This housing market dynamic, rapidly increasing housing values in previously affordable neighborhoods, is generally what people talk about when they're talking about gentrification. This research helps show the importance of policies that protect access to affordable housing for health and supports local advocates in their fights for housing justice. You can only do this kind of participatory work in a place that values community partnership and understands that putting residents at the center of place-based research improves social science. Participatory action research is just one of the ways that my students at MIT are helping to make a better world.